Dr. Badrinath Talwar for the clear and systematic guide on SICS. Your detailed explanation will certainly help young surgeons refine their skills. May I now request Dr. Rajni Kadri to kindly present a token of appreciation to Dr. Badrinath Talwar. Phacoemulsification has revolutionized cataract surgery, and proper training is the key to performing it with confidence and precision. To talk about this, I am delighted to invite Dr. Shaman Shetty to the stage. May we please have you on the stage, sir? Next, you can change the slides.
I thank the whole AJ team, Kudwa sir, Rajni ma'am, thank you for having me. Thank you for this opportunity, and thank you everyone for here. This basically, I think I'll just try to tell you some things which I think, you read theoretically, but some I'll try to give a practical insight which can help you fine tune your skills. These are things which I think I learned at over a period of time, which I could fine tune it or learn by while teaching to others. So first is the biggest tip which we all have, like the failure. If we have a drop, if something happens, the failure, like when we know SIC is good, and again some kind of setback happens and we don't want to touch anything like this again. This 90% of us have. I can, openly tell you, like my first case as a phaco, I had a drop. I had done almost around 500 SICS at a good stretch. Everything is going fine. My first case is a drop. My confidence is shattered. Everything has gone wrong. I know, like, my patient is going to go next to the retina OT and it has to be managed right now. All said and done. So I'll show later where I actually went wrong. But when it goes wrong, your morale is shattered. So, but now the next best thing, two things which came to my mind. Now I'm anyways good in SICS, let me stick to this. Why this nonsense like this? This is not my cup of tea. My trainer and mentor said something to me which, kind of stuck to me, and it's still there. I tell this to other people, whoever it can help in any small way it is. You come to learn. This is a learning mistake. It's not a crime. A learning mistake is, there is a mistake which has happened unintentionally. It's not without your knowledge. Crime is where you know a certain thing and you're doing it intentionally. So a learning mistake is always forgivable because you don't know where it has gone wrong. What kind of, your step you have done which has gone wrong, but you go to assess where it has gone wrong, you try to rectify it. So that is how we have to, proceed. That gave me a push, like, okay, let me try to better it, let me try to learn where it went wrong, let me correct it, so that, I can improvise. So that will give you a confidence to go ahead. If we get stuck with one, liability, that should not make us just sit back. I'm just telling this because it should give confidence to others, like, don't stop. If you had a setback, it's fine. Just realize where it has gone wrong and try to, better it. This is something which again we have to keep in mind, to keep our ego out. We need to, certainly when we go to learn from others, we need to keep our age, whatever degrees, whichever things we have, to keep it aside. They might tell you the same 10 things or 9 things which you already know theoretically. It's there in the books, it's there in the videos, everything. But there might be that 1 to 2 catch points which that person might tell, can actually help you out. It might be a very easy manual which can simplify things. So please be open to learn. It's not like only you know the best. If that is the attitude which is going to go, then it's not the right thing. Be open to learn things from others. Maybe it's your colleague, your senior, your junior, whoever it is. But that openness will, simplify things for you. And that's how it has to be. Knowing SICS will give you a confidence in phaco, because why? Something goes wrong, there's always something to switch back to. Because suddenly what happens in phaco when you're doing, it takes a little bit bigger learning curve than your SICS. Each case is different, each thing what you do is different, each maneuvering, each technique, that to improvise and to get fine will take little time. So for that, knowing your SICS, if something goes wrong, something to fall back on, always helps you. So the surgical steps is usually pretty simple. A surgeon starts the surgery, he adjusts your phaco settings, he'll press his foot pedal, aspiration happens, the whole surgery is complete. This is basically how your phaco starts. But as a beginner, you need to know how you're going to go about it, what cases that you need to choose, what not to. Going on first with trying to go, like on table you have a subluxated, a mature or a dark black cataract, that is only going to decrease your confidence rather than anything. Pre-op things, just make sure like you grade your cataract correctly. It is soft, hard, mature. See your pupil dilatation correctly, because the time you go inside and you have a small pupil, as a beginner, it's not good. IOL power, what it is, and especially your ECD, more than 3 millimeters, usually again it's going to be a problem. If possible to see your endothelial count, see that. A golden rule, whenever you're going to sit, always sit and see your settings. Don't go by settings of someone else. You have to see your settings according to your grade of cataract and what settings you are comfortable with. An expert setting, if you are going to go and sit with that setting, that is not going to help you. So always see your settings, see your bottle height, see how much water is there in your bottle. Everything is very important when you sit. Next is your sitting position. First, it's always better that you be comfortable, make your patient comfortable, then the rest follows. If you are not sitting correctly, the patient is not sitting correctly, the head posture, everything has gone wrong, then that's not going to be a correct thing to start off with. A site of incision, see, it's again up to you. Like how I think Vijay sir showed his case, like, it's from superior, it's better to keep your hands, everything. It's one kind of a thing. But again, you can see there are advantages of it. Like how sir pointed out, you can rest out your hands. Incision is in the superior, your upper lid can cover it. There is a slight disadvantage in case of your like deep set eyes, or we have a smaller palpebral fissure. So those kind of this is a slight setback. But if you're going temporal, that's also a good method. I use temporal because I'm more comfortable with it. I have a wider range, I have a bigger place, I can keep my hand. There is my hands are free to move for my chopping things also. And even if it is deep set eyes or whatever, it's not a problem. But yeah, like my incisions are not correct or anything, the pooling can happen. Sometimes your eyes can go a little nasally. So those are the again disadvantage what can happen. But it's left to you. You can choose whatever you want, but choose wisely, like how you want it and how you can correct it. There are usually 3 types of incisions which people follow. One, scleral. Yes, like as an initial beginner, you want to do a small scleral incision and then try to do your phaco, because if something goes wrong, you need something to fall back on. Second is limbal. Too much of limbal, if you're going to go in, again, you're going to end up with ballooning. That's again going to hamper your surgery. Too much of clear corneal, you're going to go, again, you're going to end up with wound burn. So exact a little bit between a slightly above limbal, it's going to be a little better, but you can go ahead with however, according to your case wise. Yeah, so a little bit I can just tell you about the incision to fine tuners. There is usually 3 types of steps which you can use. One is a one step which you can go deep and just enter it. It's very easy to put your probe to finish off your surgery. The only disadvantage is when it comes to your sealing things. The second is, yeah, I think you are able to see this. Second is usually what in a 2-step what you do is lightly you're going to make a groove, you're going to go 1 step and then you're going to go inside. So this what happens, it's slightly much more better than your 1 step, sealing is much better. Next comes is like what you call as like a 3-step. In 3-step, what happens? Your astigmatism is still reduced. The chances of your not getting a full seal is very less. So it's still much more better. So if you can, incorporate it into your surgical, into your phaco cases, it will be helpful, because rather than straight taking an entry blade and directly going in. So these kind of small things, it helps us refine our surgical skills. Paracentesis is usually only like what sir showed. You take a side port or your MVR blade where you're going to do your rexus, basically make it such that your viscocannula can go inside and come out. The other chopper side should only be so much that only your chopper can go inside. Too much if you try to make it, then again you're going to have a leak there where your antechamber is not going to form. So this is, I'm just putting a pictorial representation. See, the first where like I'm showing, it's like a good, because you have like at least 2 to 3 clock hours away from your main site of incision. So this, what happens, it gives you a free flow for your hands to move. Your left hand has to keep moving, or whichever hand you are, that hand has to keep moving towards your phaco tip or movement of the nucleus. Again, in the same, when you're seeing in the second thing, it's very close. So very close, what happens when your probe and your chopper is going to be very close to each other, which it becomes very difficult for you to initiate a crack and to do multiple cracks and to give to eat it up. Can we play this, please? Both, if it's possible. Yeah. So you're seeing that, like in the first thing, it's at least 2 to 3 clock hours there, it's there, but you're putting like, your type of incision is not correct. That's why you're seeing the ballooning happening there. In the second video, you're giving excess phaco, it's very close, and you're seeing a wound burn. We are not realizing this, but these small things, like slightly giving 2 to 3 clock hours away for your chopper, making your wound right, these kind of trouble, it saves you. Getting your rexus. Once you become little better, yes, you aim for a 5.5 to put your multifocals, all that premium lenses, it is better. But as a beginner, it's always better that you get a 6 to 6.5 millimeter rexus, so that like, you need to do your trenching, you need to split, you need to eat. So for this procedures to do, so you get a big rexus as a beginner, it is better. Once you fine tune it, you go to a smaller ones. Hydro is basically what, now it's exactly little different from what you do in SICS. SICS, you want your hydro to pop out the nucleus, but here you want it to be inside the rexus. Here, because you're going to take a probe, you want to do all your circus there, so you want the nucleus to be there. So, but when you do a hydro, the basic thing is, at least before you start your phaco, at least 3 clock hours it should move. If that is able to move, that means your entire nucleus is going to move. Maintaining your fluid balance in phaco, because we always used, get scared of the term surge or how the fluidics happen in phaco. It's usually gravity based. You see any normal old or regular phaco machines, it's all dependent on your bottle height. Usually around 90 centimeters above your head, that is how it is going to be placed. So this fluid is going to, come into your eye, your pressure is generated, there is a fluid inflow, there is an outflow, and that is how a balance is achieved. Whenever this is going to create an imbalance there, that is where you're going to have a problem. Normal in your phaco, it is again, yes, it's like an unified control system which you have. There is a power which is going to be delivered, and there is a vacuum which you can control it. The emulsification happens in a very simple format. You are applying an ultrasound that is going to fragment the lens. With your aspiration, that is going to be emulsified. So I have just simplified it so that you can understand it. So how are you going to, crack it open? Usually there are 3 things, which is 3 usual simple techniques which you used. Either it's a stop and chop, divide and conquer, or your direct chop. So the normal trench, what happens is, what you see, like, within the rexus, when you come in with your phaco probe, from your one end of your starting of your rexus till the another, you have to be in the same group. Like how we tell, like you go to an ice cream parlor and they're going to scoop a layer of ice cream. The deeper you go, that is going to be a deep scoop. So you start when you're coming to the middle, you give a little bit more ultrasound. When you're coming towards the end, you lessen it. You stop, you come back, and you start from the same groove. You go 80% depth, or at least until you see like a red glow. It's not like you keep going, you keep digging until the whole thing gives away. You should know how you have realized like an 80% of your depth of your nucleus is correct. Then you can try to, split it. If that is not happening, rotate it again and again deepen it. That's all it is. But when you're going to split it, there are two usual methods like what people follow. One, you use the same probe and you want to use the chopper and try to do that. That is again happens when you have a very good foot control and that you're able to do it. But as a beginner, if you're not able to do it, put visco, take 2 choppers. The pressure only has to be on your fingertips. It's not on your wrist. So just keep it over the groove and try to, only it's just like a splitting motion. It's not like you try to rip it like open a shirt. That's the time when you try to do it like, AC starts collapsing. So the pressure is only on the fingertips. You try to split it. Once you have a split, then you're ready for your phaco 2. Maintain the groove. If you're going to try to make multiple grooves, then you're going to create a crater, which again you yourself are going to have difficulty to again split it again into multiple pieces. Because in phaco 2, again you need to do a horizontal chop to break the nucleus. So you will never get a grip. So initially it is very important that you do a correct trench, be in the same length, start, middle you try to trench more, when you're coming to the end stop. I am showing this video why, because initially when you start, there is so much of knowledge with us, like you have read your dynamics, you have done everything, then you are concentrating same things. Your hand, your eyes and your foot has to be in the state, like present state of mind, because something goes wrong, you don't know what is happening. This is exactly the step where I went wrong in my first case. I got everything right. When I started my trench, but when I had to stop and to come back, my foot didn't stop. It just extended my rhexis. That gave way for my nucleus to fall down. I didn't realize it that time. After it fell, once when the retina people were clearing, then I realized, okay, my foot pedal didn't stop. I had overpressed my foot pedal. It just took off. So that's the small things, like it makes a matter. You start, you stop. But just don't give giving phaco. You come back, you start from the same line, deepen it, stop, come back, start. Until you see like you got a good groove, that itself like, it'll save you a little problem. Can we increase the sound or something? Yeah, so I'm telling this why, because in this part of listen to the sound means, here you need to listen when the vacuum is going to build, especially in your phaco 2. Phaco 2, when you're going to aspirate all the cortex, you're going to go with your probe and you're going to touch the nucleus. It's always better that you touch the cortex, like, the core, you touch the core of the nucleus, because that is where you want the vacuum to build. Once that vacuum is built, you are going to, see, this is how like the aspiration is going to start. This sound is the sound when the vacuum is built. Your probe is already in contact with the nucleus and it is the vacuum of your desired choice is built. So that is the time you need to go and chop. Before that, if you're just going to press your foot, you're just going to be in an ultrasound 3 and you're just going to be around there, not going to build any vacuum, or not going to be able to do anything. It's why, because only when this vacuum is built, you have your capacity, you have the movement to use your left hand to go and do a chop. So in this chop now, usually there are two things. Either there is an horizontal chop or you're directly going into a vertical chop. Horizontal chop, when you're coming into phaco 2, this is a small tip which I'm telling you. Please forget your trench action here. How we are going to go in phaco 1 with you're going to keep trenching. In phaco 2, try not to do that. Your idea is what? You need to take the piece, come to the center, be in the center, your probe has to be stable, your left hand has to move, eat it up. Here, if you keep going around with your probe here and there, your vacuum is more. It's somewhere or the other, it's not going to be in your control where you're going to have problems. So the tip is like, forget your trench movement. Try as much as possible to keep your probe stable. So the next is like, how you are going to split it. In horizontal chop, you are going to use a blunt chopper. You are going to go little behind your rexus and try to make like an inverted L split. That is how it has to happen. As a beginner, if you are finding it difficult, you split again the nucleus into 4 quadrant, which again can help you to hold it, like how you have done the 2 quadrant with your trench, the same you do with your 4. Once those are 4 small pieces, it's much more easier for you to go hold a piece, get it towards the center. The probe should not be facing up nor too down, it has to be middle, and you start doing it. Vertical chop, it's usually again more of your NS2 to 3 little bit, or if you have some little smaller cases, but it will help if you have a little sharper chopper here, because you are going to be in the center and from there only you want to split it open. So this is again like once you are fine tuned with your horizontal chop, then this technique can help it much more better. Coming to the epinucleus part. So you finish your major part and now you're coming to the epinuclear part. This is the soft part. This is again where you get scared, like your foot pedal is not in your control. Something can go wrong anywhere. There is a thin sheet. If you put your foot somewhere, it's not going to be a control. So easier thing is if you feel it's not loosen, it's not coming close to you, means either again you go just to a hydro on the sides, so that will loosen it, or even you can put a visco and just try to use the dialer and loosen the epinuclear plate, so that loosens up. Once that is loosened, then you can go into your epi mode and then eat it up. When it's coming to the last piece, always be careful like about your foot movement. When the nucleus is going to touch your phaco probe, no matter what it is, you make sure your left hand is moving, you're eating the piece. Once that piece is eaten, you come back to 2. It is 2-3 foot pedal movement. If you cannot be in 3 or 2, if you are only in 2, you are not going to emulsify the nucleus. If you are in 3, you are just giving power, but you are not holding on to anything. So when again you are moving on to your cortex clearance, initially as a beginner, it is always better you start off with Simcoe. Why Simcoe? Because you need to have your hand and your foot control. So that will help you at least some 15-20 cases. You have your control over your Simcoe cannula to remove it. Then you go to the bimanual. Then you go to coaxial. Bimanual also, we tell this why, because it's a transition. It's a transition for you to gain confidence with your foot, gain confidence with your hand, and you see how the cortex is getting removed. If not, then again this is where the smaller things which can go wrong to you. Lastly, even for the IOL, even till the time you take the IOL, and as sir said, like slowly you wait for the front and the last haptic to come. That is how. You just don't need to fast, just try to and push it. There is nothing wrong like in using like a wound assisted method, like how sir showed, like using a dialer which can stabilize your globe, and that helps you to put the lens. Because sometimes when you're going to use the injector and put it, invariably the eye will move. So that times you don't know where it is going. If it is not going, either it is going to come, or like you will, this is again half the times either you're pushing too fast, which is going to end up with a PCR, or you are going to end up with an IOL getting cut somewhere. So it's always better use whatever method suits you, fine tune it. So I'll just summarize the things. Means choose your case correctly when you're starting, optimize your microscope setting and your phaco settings. Create your settings again. As a beginner, I will always suggest you go in a linear mode. Linear mode is much better, like when it is in your control, rather than going to an expert mode. Expert is usually like what people are very fast, they used to fixed mode. Fixed mode as a beginner, it becomes very difficult, because the time you put your foot pedal, everything is in a F1 track. But being in a linear mode, it is going to take little time, but it is there in your control. Everything is in your control. You are able to do things on your own. So it is better that you keep your settings as linear in any kind of a machine when you are going. Gentle hydro, start with your divide and conquer, then you move on to the vertical chop, stabilize your hand movements, and as I said, inject IOL gently attack. So I concluded, like you need to know your dynamics. You need to know what is happening, why it is happening, what is pulse, what is burst, what are the modes, what's happening. Then you need to understand about your machine. So understanding a machine will help you to fine tune your surgical things. You should know when you need to convert. If you are not able to manage, ask for help. Review your videos. You need to record it. You need to know where it went wrong, why it went wrong. Can you fine tune it? Is there some thing which you can do which can decrease your phaco time? All that things will help you. So yeah, it has a longer learning curve, but it's not an impossible learning curve. So yeah, just keep it in mind and keep doing surgeries. That's all I'll tell. Thank you for your time.
Thank you, Dr. Shaman Shetty, for guiding us through the nuances of emulsification training. Your insights will inspire learners to approach this technique with clarity and skill. May I now request Dr. Akansha Shetty to kindly present a token of appreciation to Dr. Shaman Shetty.